Live.
Someone should give us a countdown.
Yeah. Yes, sir. Yes, sir. We're in live, sir. Please go ahead.
Hi, good evening, everybody. On behalf of Department of Gastroenterology, KEM Hospital, and all the August faculty who are here, I would like to welcome you for this wonderful evening. In the next hour or so, we'll be discussing about the nuances of post-ERCP pancreatitis, its prophylaxis, and how do we diagnose it, and what should be our approach towards the basics of the management. But our predominant focus will be on prevention. So without wasting much time, I would like to invite Dr. Sridhar Sundaram, Assistant Professor, Department of Gastroenterology at KEM Hospital, to give us a brief background of what this post-ERCP pancreatitis is all about. This will be followed by a panel discussion where we have very eminent panelists like Professor Praveen Rathi, Professor and Head Department of Gastroenterology at Nair Hospital, Dr. Pankaj Dhawan, formerly Associate Professor, Department of Gastroenterology at KEM and Nair Hospital, and one of the leading endoscopists of the country. We have Dr. Vikas Pandey, Associate Professor, Department of Gastroenterology at Sion Hospital, Professor Meghraj Ingle, Head of the Department of Gastroenterology at Sion Hospital, and Dr. Aditya Kare, who is the Assistant Professor, Department of Gastroenterology at KEM Hospital. So in presence of such a wonderful August gathering, I really welcome you all on behalf of the department for this wonderful feast of academic for the next hour or so. It's over to you now, Sridhar.
Thank you so much, sir, for the wonderful introduction. Are my slides visible?
Yes.
Yeah. So a very good evening to one and all. I'll be presenting in a brief summary of all the evidence available for prophylaxis of post-ERCP pancreatitis. ERCP was first performed by Professor William McCune in George Washington University in Washington, DC in the year 1968. He used something called the Eder fiber optic duodenoscope, which was built in an auto repair shop by a repair person called Herman. I mean, we don't have any details of that person, but he built it. And with his friend Louis Streifeder, he performed the first ERCP, which was basically a pancreatogram that he did. Now, what he started has had multiplicative effects over the years, and subsequently the Japanese took over. Professor Dr. Itaru Oi and his chief Professor Takimoto in the year 1969 devised something called the Machida scope, which was a side viewing duodenoscope for cannulation of the ampulla of Vater, and they showed success in up to 71% of cases. And then started the phase of American endoscopic madness, with stalwarts like Cotton, Jeanin, Klassen coming in, and the cannulation success rates increasing to 80 to 90%. So you can see that there were multiple studies published during this period, all showing cannulation success rates between 80 to 90%. And these were all with instruments that were reasonably primitive when you compare it to the instruments that we use today. However, when they started doing this, the primary concern was how to make the ERCP safer. They found increasing incidence of pancreatitis. Cotton, in his initial reports, said that pancreatitis was there to the tune of around 40%. So there were some issues that really needed to be addressed with regards to pancreatitis. And the questions that arose were how to identify patients who are at risk, if endoscopic experience actually impacted the incidence of post-ERCP pancreatitis. Are there any medications which will impact the risk of PEP? Also, are there any procedural factors which increase risk? Any procedural interventions which may actually reduce risk? Some things that can be done as therapeutic measures to reduce the impact and the severity of the pancreatitis that actually develops. And lastly, something that became significant was the cost and practicability of all of these interventions, whether they can be used routinely in clinical practice or not. So we cut the chase to around 5 decades later, and there's a large volume of data now available on post-ERCP pancreatitis. So we all know right now that post-ERCP pancreatitis is the most common complication that is seen after ERCP. the incidence being anywhere between 4 to 10%, around 15% in high-risk patients. It is usually mild in most patients, and the mortality is low, around 0.1 to 0.7%. But there is significant amount of morbidity, and that is what is worrisome to most endoscopists. Now, to define pancreatitis, Cotton gave his criteria in the year 1990, and he defined it as clinical pancreatitis with amylase measured at more than 24 hours after the procedure, which was more than 3 times the upper limit of normal, and something that requires admission or prolongation of a planned admission to 2 to 3 days. There was, of course, severity that was also defined to moderate and severe. The Cotton criteria has been superseded by the revised Atlanta classification, which is used most often now to define the severity of pancreatitis, to define whether there is pancreatitis and also the severity of pancreatitis. So there have been risk factors that have been defined over the years, multiple studies done. So there are patient-related definitive risk factors like suspected SOD, that is sphincter of Oddi dysfunction, female sex, history of pancreatitis, history of previous post-ERCP pancreatitis. And again, some other factors that are patient-related, like a younger age, a non-dilated duct, absence of chronic pancreatitis, normal bilirubin, and end-stage renal disease. There were some procedural factors that were also associated with risk, like difficult cannulation, which was maybe attempt at cannulation more than 5 times for more than 5 minutes, a pancreatic guide wire passage that was more than once, pancreatic injection, and some factors which may or may not be related, like precut sphincterotomy, pancreatic sphincterotomy, a balloon dilatation on an intact sphincter, failure to clear the bile duct stones, and intrarectal ultrasound. So the predictive factors of PEP are usually multiplicators. So if you have 2 or 3 factors, the risk increases 2 or 3-fold. So female patients with SOD were at very high risk and very high, they usually had the most severe pancreatitis. But there are some clinical characteristics that actually reduce the risk of PEP. This includes previous sphincterotomy, history of chronic pancreatitis, advanced age, pancreatic head malignancy, and there is some amount of data which says that the higher the volume that the endoscopist has performed, the lesser the risk of pancreatitis, although the data is not very robust. So my talk primarily focus on how to prevent pancreatitis. Now, there can be 3 strategies that are used for PEP prevention. The first being patient selection, pharmacologic interventions, and procedural interventions. So primarily coming to patient selection, now ERCP is no longer a diagnostic modality which it used to be maybe around 20 years back. So primarily, it remains a therapeutic modality. There is really no role for ERCP in unexplained pancreatobiliary pain. The episode study recently, the long-term data for which was published in GI in 2018 also showed that even in patients with type 3 SOD, sphincter of Oddi dysfunction, where it was only unexplained pancreatobiliary pain, there was really no difference between a sphincterotomy and sham intervention. So ERCP still remains for the patients who have an absolute indication to do the procedure. So EUS and MRCP have replaced ERCP as diagnostic modalities. Even in patients where there is suspected choledocholitis, both ASGE and ESG have given criteria to define risk of choledocholitis, and EUS can be performed prior to the ERCP, and based on that, the use of ERCP may reduce by 60 to 70%. Now, next comes the pharmacologic intervention. Now, this is where the primary focus lies. The primary pharmacologic intervention that we use are rectal NSAIDs. Now, although there was a large amount of data that started coming in for NSAIDs from 1999, there are multiple RCTs that have come. But the landmark trial was performed by El-Manzar in the year 2012. This was published in NEJM, RCT of 602 patients who underwent TRCP. 81% actually had the indication being sphincter of Oddi dysfunction, and they were randomized to receive rectal indomethacin versus placebo. So you can see that the rate of pancreatitis was around 17% for those who received placebo and around 9.2% for those who received indomethacin. Also, the risk of severity of pancreatitis was lesser in those who received indomethacin. Now, how indomethacin acts is that they are potent inhibitors of cyclooxygenase, phospholipase A2, and neutrophil endothelial interactions, and hence they reduce the risk. Now, there have been multiple trials that have actually compared the use of oral NSAIDs, rectal NSAIDs, and intramuscular NSAIDs. The trials for intramuscular and oral NSAIDs have all been negative trials. There have been almost 7 RCTs which have compared the use of rectal NSAIDs with oral NSAIDs, and all have been negative trials. So rectal NSAIDs have been proven better over oral NSAIDs over and over again. There are around 28 meta-analyses that are available that I could find on NSAIDs with placebo. So all but one show significant benefit. The number needed to treat for one episode of PEP is anywhere between 8 to 20. For reducing one episode of moderate to severe pancreatitis, the number needed to treat is 33 to 39. There have been comparisons between rectal endomethacin and diclofenac in 14 meta-analysis. They found to be similar in efficacy, the best dose being around 100 milligrams. There has been a lot of debate on whether we should be giving NSAIDs pre-procedure or post-procedure. There has been one RCT of around 2,600 patients where they compared pre-procedure versus post-procedure. And they found that pre-procedure NSAIDs were better in high and average risk patients. So there was really no difference in the adverse effects. So pre-procedure administration remains the best strategy in these patients. Now, NSAIDs cannot be given to all patients. NSAIDs are preferably avoided in patients with renal disease. Even in pregnant women beyond 30 weeks of gestation, there might be a premature closure of the ductus arteriosus. So it is better to be careful in these patients. And there are some patients who do complain of allergic and pseudo-allergic reactions. So although there is no real increased bleeding risk with aspirin, clopidogrel, or any antithrombotics. So NSAIDs have to be used in caution with a certain group of patients, but in general, they are a very safe category of drugs which can be used for most patients that come to us in our practice. Now, apart from NSAIDs, the second strategy that is commonly used is aggressive IV hydration. Now, aggressive IV hydration was defined by Cho et al. In their study, where they gave around 3 ml per kg per hour during the ERCP, followed by 20 ml per kg IV bolus after the ERCP, and 3 ml per kg per hour for around 8 hours after. So this came down to around a 2.5 liter fluid that bolus that we were totally giving in toto. And they showed that the incidence of PEP reduced in those who received aggressive hydration versus those who did not. Now, aggressive hydration reduced the risk of PEP in another study also published recently in Pancreatology in 2019 by almost 56% and reduced the hospital stay by 1 day. Now, there was another trial called the India trial, which was started on the use of NSAIDs with epinephrine, topical epinephrine. And even in that, they actually found that higher fluid volume and the use of ringalactate was associated with, in the peri-procedural period, was associated with the lower incidence of PEP. Now, primary caution is in older patients and those with heart and kidney disease, where we cannot give such high volume of fluids. Again, another thing is that aggressive hydration, although can be given for patients who are at high risk, but sometimes we do perform ERCPs as outpatient procedures. So in those patients where, who are categorized as low risk, the appropriateness of aggressive hydration is yet to be established. The third agent is glyceryl trinitrate. Now, sublingual nitroglycerin 5 mg is easily available in the market, can be easily given to patients. Now, as per recommendation, it can be used in patients where NSAIDs and aggressive hydration are contraindicated. There is a meta-analysis of almost 12 trials, wherein they showed that nitroglycerin reduced the risk by 33%, although it did not change the severity of pancreatitis. Now, intravenous nitroglycerin is avoided. However, there has been studies on combination with indomethacin suppository, and they found that the combination was better than indomethacin or diclofenac alone. But unfortunately, in both of these trials, the one that is published in American Journal of Gastroenterology in 2014 and in Gastroenterology in 2019, the dose of the NSAID use was suboptimal. The dose was only 50 mg that was used as against the standard recommendation of 100 mg. That is recommended both by the ASG, ESG. So again, the combination cannot be a recommendation as of now because the studies are not good. However, they can be used as alternatives where NSAIDs cannot be given to patients. There are trials on other medications like somatostatin, octreotide, and protease inhibitors, but there are multiple studies all having conflicting results. So there is really no recommendation on any of these drugs being used for prophylaxis against post-ERCP pancreatitis. Now comes the important part of procedural intervention. Now, there is a lot of data on guide wire assisted cannulation, which of course hold benefit over the contrast assisted cannulation. I guess all of us in practice have switched to guide wire assisted cannulation. No one really uses contrast assisted cannulation. However, sometimes, we really need to understand how much the risk actually changes. The risk reduces by around 49%, so almost by half. Again, sometimes inadvertently the pancreatic duct may get cannulated. In those situations, there is an increased risk of PEP as compared to other techniques when you do a precut syncrotomy or cannulation alongside a pancreatic stent. So there is a lot of data on early pre-cut. Now, why I'm saying early pre-cut is because sometimes we give multiple attempts at a difficult biliary cannulation, which tends to lead to trauma of the pancreatic sphincter and may lead to edema and eventually post-ERCP pancreatitis. Now, in those situations, an early pre-cut is sometimes warranted. Now, there have been multiple studies over the years. First, in 2010, published in Endoscopy, wherein they showed that early pre-cut reduced the absolute risk by 2.8%. In another study in 2016, some patients actually underwent a primary pre-cut instead of a late pre-cut. I mean, the very first attempt was actually a pre-cut. And they showed that the post-ERCP pancreatitis risk was lower by 65% in patients. A recent study from Jaipur in India, published in GI Endoscopy, showed that early pre-cut after 2 failed cannulation attempts was associated with lower PP than delayed pre-cut. So in a previous RTT, again, it was shown that pre-cut over a pancreatic stent was found to have a lesser incidence of PP rather than a freehand technique. So there is a reasonable amount of data to say that in a patient with difficult biliary cannulation, it is best that we do not wait longer to actually attempt a pre-cut. We do it reasonably early, preferably done by an expert endoscopist, so as to reduce the risk of PEP. Important would be the pancreatic stent placement. It reduces the PP by relieving the ductal hypertension that develops as a result of stenosis of the pancreatic orifice that may occur because of edema after the procedure. So the risk reduces by around 60%. There are some disadvantages, of course. Now, sometimes we might want to place the stent, but we may fail to place the stent, and we may actually inadvertently injure the pancreatic orifice even more, and may lead to increased risk of PEP. Sometimes there can be internal migration of the stent, may have some duct perforation. Sometimes prolonged stent placement may lead to CP-like changes. So there have been multiple meta-analysis. Now, 2 meta-analysis that have the maximum number of subjects I've quoted. The first one with around 1,500 subjects. You can see that there was significant reduction in the incidence of PEP in these studies. Now, if you look at the risk stratification, around 55% reduced risk of mild pancreatitis, and also around 74% reduced risk of severe pancreatitis was seen in these studies. In another meta-analysis of almost 3,300 patients, it was found that the risk of mild PEP in the patients who actually had a stent versus no stent was much lower in those who actually had a stent. Even the moderate and severe pancreatitis was much lower in those who actually had a stent placed. So stent has always been an important strategy to prevent post-ERCP pancreatitis. Now, prophylactic pancreatic stenting decreases the risk of PEP in high risk and mixed case groups. It nearly eliminates the risk of severe pancreatitis. Now, the standard practice is all of us use 5 French pancreatic stents, which have been proven to be more efficacious than 3 French pancreatic stents. There is a single RCT that is also available on the size of the stent, wherein they compared 5 French 3 centimeter versus 5 French 5 centimeter. And they actually found that the 5 French 3 centimeter was better. But unusually, the study also said that placing the 5 French 3 centimeter stent was sometimes difficult because it was really short. So, which is why I guess 5 French 5 centimeter is the standard length that is available in practice. So even the ESG recommends that we use a 5 French pancreatic stent in those with high risk of PEP. And ideally, the stent should be removed within 5 to 10 days of the placement. So ideally, we give appointment to remove the stent after 5 to 10 days for these patients. Now, there can be combination of different agents that can be used, like NSAIDs can be used with stents. There are RCTs that have been published on the combination of pancreatic stents in those with high risk along with NSAIDs. And they actually found that there was really no difference between the combination and the use of NSAIDs alone. Although there is really no data available as a head-to-head comparison between pancreatic stent alone versus NSAIDs alone. Also, like I've already discussed, there is the benefit of combining NSAIDs and sublingual nitroglycerin was shown in 2 RCTs, but there were some methodological issues in both the RCTs. So hence that cannot be recommended as of now. And again, like I mentioned, the India trial and 2 other trials that have been done in 2019 showed that there was really no role of NSAIDs being combined with topical epinephrine either. So although sometimes in patients with high risk, we do place a pancreatic stent, we might also give an NSAID in addition. At least based on the trials, there is really no evidence to suggest a synergistic effect of both the interventions. So to simplify our strategy, if there is any contraindication to the if there is no contraindication to the NSAID, ideally for every patient who undergoes an ERCP, rectal indomethacin or diclofenac 100 mg has to be administered. As far as the intervention is considered, we use standard wire-guided cannulation techniques. If there is a difficult cannulation with easy pancreatic stent place, there has been multiple guide wire passages into the pancreas. We usually place a pancreatic stent. Ideally, if there is no contraindication to high volume hydration, we also give high volume hydration. Again, there is no study to suggest that NSAIDs and high volume hydration may have a better effect. That is something that we can look into maybe in the future, wherein we can actually look at combination of both the interventions together. So like there are basically 3 interventions that can be done at the moment: NSAIDs, aggressive hydration, and in patients who have contraindication to both of these, sublingual nitroglycerin can be used, 5 mg, and pancreatic stents in situations where there was inadvertent pancreatic duct cannulation that was done multiple times. Thank you. Akash sir, I think.
Thank you, Sridhar. Thank you for this wonderful talk. Any questions, anybody? Any comments?
Yeah, Sridhar, can I ask you a question?
Yes, sir.
Why rectal is preferred over oral indomethacin? Though trials have proven rectal to be better than oral indomethacin, but why is it so?
So there is apparently the rectal suppository gets absorbed directly from the rectal mucosa. So there is some amount of first pass metabolism that the oral indomethacin that is given undergoes. So which is why the rectal is apparently better. Now that is the hypothesis. There is really no evidence. There has been no study on what the drug levels are, which is again some area that can be looked into. A recent study published in Digestive Disease Sciences actually tried to look at the drug levels. So they found that the rectal drug level, they had only around 8 patients that they took, and they found that the drug levels when administered rectally were higher than when it was administered orally. But again, that's a small series to go by. So I think we need a larger volume of data before we can actually say the drug levels are more. But otherwise, I mean, the hypothesis is that there is no first pass metabolism, so which is why.
So what I feel is, just to add on to it, just one comment is, since most of times ERCP is a procedure which we would be doing in sedation or under a mild GA, so giving oral just before is going to be sort of a counterproductive from the anesthesia point of view. And rectal is always easy to give just pre-procedure, an hour pre-procedure, intra-procedure, or even immediately after procedure. Again, in a sedated patient, to give anything orally is going to be risky, and the anesthesia we would also not be very comfortable. So that is one reason. But yes, we still don't know, as Sridhar said, why in that study in which they tried multiple formulations, including IV, IM, oral, and rectal, they have shown that rectal is beneficial. One of the reasons, as Sridhar said, could be because the absorption is immediate and does not depend upon the patient's status, whether gastroparesis or obstruction or whatever. So the rectal will get absorbed immediately. Yeah.
Sridhar, I wanted to ask a question. Why do you think there is a difference between the different NSAIDs? Why indomethacin scores over the others?
Sir, so I mean, there have been trials on indomethacin and diclofenac primarily, and the safety profile for both these drugs they're time-tested drugs, and which is why I guess indomethacin has always been the preferred agent, even for both the ESD and the ASD guidelines. They are time-tested agents. They've been safe. They have a very good safety profile. So clearly, which is why I guess they score over all the other agents.
I'll tell you the reason. I am always intrigued by this because I remember when in earlier days, the drug of choice for rheumatological disorders, rheumatoid arthritis or ankylosing spondylitis, was actually indomethacin. And I remember seeing prescriptions of the yesteryears, which would almost always have indomethacin. But after the COX-2 inhibitors have come, and I hardly see prescriptions of indomethacin except from teaching institutes where it is the only drug which is freely available and not other drugs. So yes, efficacy, yes, but I think, do you think it's as safe as the others? And are there any trials with COX-2 inhibitors?
At least not for post-ERCP pancreatitis as an indication. We are giving this as a single dose, so again, no real hard data on COX-2 inhibitors.
Yeah, so probably with a single dose, you are not so much worried about renal side effects or GI side effects also.
Absolutely.
Akash, actually, there were trials with selective COX-2 inhibitors, and they didn't find it to prevent post-ERCP pancreatitis. So for some reason, there was a beneficial effect only with indomethacin and to some extent diclofenac, and that too in the suppository form.
The reason for that was being the COX-2 pathway is not that much activated in most of the phospholipase activation, which
phospholipase A,
yeah. So that is the reason probably COX-2 don't work and phospholipase inhibitors work more.
Yeah,
that was the reason.
That's
Sridhar, what about, would you like to prefer to give a restricted fluid infusion or aggressive hydration?
So as standard practice, sir, for patients over here, if there's no contraindication, we do give aggressive hydration. So, but aggressive hydration as prescribed by the study in Choi et al. Or even in the guideline, that amounts to almost 2.5 liters of fluid. We don't give as much. We give somewhere close to between 1 to 1.5.
So restricted you'll prefer.
Yeah. But I mean, I won't call that restricted, but nevertheless, somewhere in between.
Okay.
So it can be given only for the admitted patients, which
yeah, absolutely.
Because
absolutely.
what happens is that if you are doing hydration, you have to give it for 8 hours post ERCP also.
Yeah.
With pre, intra, and post, so that becomes a little bit of a, because otherwise it's not really going to work.
Okay. Thank you very much, Sridhar. I would request all the audience to please put their questions in the question box. And there is a query from Dr. Sanjay Chandani. The first question he has asked is, any specific mechanism why rectal indomethacin acts and not oral or IV, which you have answered. Query from Dr. Ajay Chaudhary is, can pancreatitis will cure? I think he wants to ask, can pancreatitis be cured? I think he refers to chronic pancreatitis, which to as of now, we don't have a cure, but I think acute pancreatitis definitely can be cured. So the next question by Dr. Suprabhat, I think Dr. Praveen Rathi has already asked. There are multiple regimens on hydration, which one to be preferred? And is prophylaxis to be given in all fresh cases or only in those having at least one risk factor? This will come to in the case-based discussion. The next question also by Suprabhat, what is the ideal time to do amylase lipase level? Also will be covering in the case-based discussion. And query from Dr. Rakesh, post ERCP, after went to home, patient may suffer from pain. So can we give rectal indomethacin at home? If yes, then what would be the dose? So that's a very interesting question by Dr. Rakesh. I think it has to be Dr. Rakesh Patel. He is the only one who can ask such difficult questions.
So I guess we are using NSAIDs for prevention, and once the pains actually happened, they're not really preventing. So I think the
but will it help?
Yeah, maybe it will reduce the pain. It will reduce the pain, but may not reduce this. Again, it's a pre-procedural intervention that has shown to reduce the severity of pancreatitis. So again, we don't know if administering it post-procedure is really going to help so much.
I think it is always better to call the patient back and assess.
Absolutely.
In case the pain is severe enough. In case of mild pain, I think even oral would suffice.
Yeah.
What do you think?
Yeah, absolutely.
Okay. So I think we'll start with the case discussions. Thank you for all the questions. There are many more questions, but I would not be able to take for the want of time because some of them we'll be covering in our case-based discussion. So we move on to the case discussion. These are the cases where, some of them which we see run of the mill and some of them are unique situations. So it will be a combination. I would like to welcome once again on behalf of Gastroenterology Research Society, all the eminent panelists, Professor Rathi, Dr. Pankaj Dhawan, Dr. Meghraj Ingle, Dr. Vikas Pandey, and Dr. Aditya Kade. So starting with the case, the first case, a 44-year-old lady, asymptomatic gallstones, incidentally detected to have 1.2 centimeter CBD stone. She is planned for a ERCP. She doesn't have comorbidities, normal LFT. So Dr. Meghraj, would you like to take this case? What will be your strategy for PEP prophylaxis?
Yeah. So already this lady seems to be having at least one or two risk factors for developing post-ERCP pancreatitis. One of them is being, by normal LFT, I assume it is normal bilirubin, and relatively young age, and then a large stone. Now, for these patients, strategy, so one, I would keep in mind before the start of the procedure that this is one patient where there is more than the higher chance of, more than normal chance of developing post-ERCP pancreatitis. So prophylaxis, one, I would, since she is young, no comorbidities, I would consider restricted or aggressive IV hydration, somewhere in between. As Sridhar said, has covered in his talk, we normally don't go up to 2.5 liters, but somewhere between 1.5 to 2 liters is what we would also normally practice. As the IV hydration is ringer lactate, no comorbidity, relatively young female. So I would start her with that. So we would normally start for an hour before the procedure ringer lactate in this patient. Also, we would consider rectal NSAIDs and rectal indomethacin in this patient, again, because she has close to 3 high risk factors for developing post-ERCP pancreatitis. Coming to the procedure, now in this patient, it's a large stone, anything more than 1.2 centimeters. So I am probably anticipating the use of a balloon biliary sphincteroplasty. So a couple of things that I would normally keep in mind for doing this procedure is I would like to try for an early cannulation. Well, all of us normally try for an early cannulation in most patients. But if first or 2 attempts of wire-guided cannulation does not happen, then I would like to go for what is called as a very early biliary pre-cut in this patient and not touch the papilla too many number of times with the sphincterotome, followed by biliary sphincteroplasty, which would be required because of 1.2 centimeter stone. Again, the decision whether to go for an upfront sphincteroplasty or do a sphincterotomy, standard biliary sphincterotomy, and try a balloon sweep will depend on the location and the size and shape of the papilla when we do the ERCP. I think all of us would agree that we take that call based on how the sphincter appears and whether there is enough space to cut the papilla, or you would like to go for earlier biliary sphincteroplasty. And try to shorten the time for the procedure and avoid injection into the pancreatic duct, as it has mentioned. And if there is an inadvertent wire or contrast into this, then I would upfront put a 5 French pancreatic stent in this patient.
Okay, thank you, Meghraj. So 2 quick questions to clarify it for everybody. So hydration and indomethacin, only hydration, only indomethacin, or neither in this patient?
We normally, again, there is no data to suggest this, that hydration with indomethacin is more helpful. However, we decide that based on the patient profile, and she is a young patient, no comorbidities, can tolerate the fluid. So indomethacin is generally given to all. Fluid hydration is based, we take that call based on the patient profile and also whether she has 1 or more risk factors for developing PEP. So this patient has 2 or 3 risk factors. So here I would go with this. There is no robust, I don't think there's any study to prove that 2 is better than 1.
Perfect.
But
Great.
hydration in addition.
No, I agree with you completely, Dr. Meghraj. One more question too. I think all of you are from extremely busy units which are doing 6, 7, 8 ERCPs a day. How often can you really time your fluids of 1 hour, starting 1 hour before and continuing?
Yes.
So continuing afterwards is fine, but to start 1 hour before, I mean, it looks a bit ambitious in most of our centers.
Absolutely, especially in our teaching hospitals institute, where it is very difficult to align, because you might time it at the time of the procedure, and the procedure might finish early or late. So it's difficult time. So I totally agree with you. What we normally time to do is try to time it 30 minutes to 1 hour. This is what practically we are doing in our setting. That if there are 3 or 4 ERCPs, what we would do is that, as you would also be doing in your place, is we assess which patients are likely to be high risk and take them prior in a controlled setting, and the less risky or the redo procedures are taken lower, so that even if there's less time to give fluids, these patients can be taken out. So that's how normally we try to target practical situation. And as you rightfully said, yes, sometimes it can become a little difficult to give a 1 hour run of RL and then take the patient on table.
Sure. So I agree with you completely, Dr. Meghraj. Here we are talking of a practical situation where, as you very appropriately said, probably indomethacin would be used for majority of the cases, and fluids as and when required. I think most of us would do that. Anybody has any differing opinion? Dr. Dhawan, Dr. Rathi?
Yeah, Meghra said he would like to do upfront biliary sphincteroplasty depending upon the size of stone and all that. But will you like to do biliary sphincterotomy followed by sphincteroplasty to prevent the post ERCP pancreatitis, or upfront he would like to do biliary sphincteroplasty?
No, sir. What I meant upfront is we always generally tend to do a partial sphincterotomy before a sphincteroplasty. By upfront, I meant without giving a trial of a balloon or a basket trawl. Sometimes when we take a look at it might be reported on imaging as 1.2, but when we do a cholangio, we realize that 1.2 was probably in a more of a vertical direction, and the stone might pass out through the sphincter size that is available. So in that case, we do sometimes give a trial of a balloon or a basket.
A small biliary sphincterotomy followed by sphincteroplasty.
Yes, sphincteroplasty is always a small biliary sphincterotomy followed by a sphincteroplasty.
You're basically giving that direction to the sphincteroplasty.
Yes.
So
The only other addition is that when you're doing a balloon sphincteroplasty, it is better to keep it for about 2 minutes.
Yes.
Yeah, anything less than 1 minute is actually associated with increased risk of pancreatitis. I think that's a very, very valid point. Thank you, Dr. Dhawan, for bringing that out. That if you're doing a balloon sphincteroplasty, do it for more than a minute, at least 2 minutes or so. Anything less than 1 minute would actually increase the risk of pancreatitis. I think that's, thank you very much. I think that's very valid. Moving on to the next case. This is a 65-year-old gentleman, ERCP done for a CBD stone, complaints of moderate to severe pain in the epigastric region on the same day in the evening. So the surgery resident sends amylase and it comes out as 650 international units per ml. A CT scan is done immediately, which is normal. So there's no obvious air under diaphragm, or there is no peripancreatic fat stranding. So what should be done? Dr. Aditya, can you take this question up? So what are we dealing with? Is it pancreatitis? Is it something else? What would you label this as? Amylase is around 3 times elevated. Upper limit is 150.
Transient elevation in serum amylase can happen within 24 hours after an ERCP procedure. And by definition of post-ERCP pancreatitis, as we have seen, serum amylase or lipase levels more than 3 times upper normal limit after measured after 24 hours, and clinical pancreatitis, that clinical features of pancreatitis that constitutes the post-ERCP pancreatitis. In this case, after an ERCP, moderate to severe epigastric pain that can be due to there can be evidence perforation, or the alternative causes we also need to rule out. And a CT is probably done for that, which are shown to be a normal. So in this patient definitely warrants an admission in the ward and observation with fluids and analgesics.
So basically, what Dr. Aditya is trying to say that this could, by definition, we cannot call this as a post-ERCP pancreatitis within the first 24 hours. Clinically, it is looking like pancreatitis. The amylase is elevated, but this patient may actually develop and fulfill the criteria of pancreatitis later on. So you would start managing him as a post-ERCP pancreatitis, but you are not still sure that he is post-ERCP pancreatitis, and you still have to consider other causes. It could just, we know that some people do get some transient pain after an ERCP, which is related to the manipulation of the instruments in the duodenum, sometimes because of the stent impinging on the wall, and there could be different other reasons why this could be there. And some elevation of amylase in the first 24 hours does not indicate post-ERCP pancreatitis. So we cannot label this patient as post-ERCP pancreatitis, although you would give him fluids, hydration, and analgesics like you would give for any other patient. Anybody has any other thoughts?
Just a point that it also depends on when you're doing the CT scan. Sometimes it's very mild and you're doing a very early CT, which is
Absolutely.
not the classical pancreatic protocol. Then you can actually miss pancreatitis if it's done too early.
Absolutely right. I think can't agree more with you.
Yeah.
So that is why don't be in a hurry to do these procedures on the same day evening, unless clinically warranted and you're really suspecting a perforation or something.
Yeah. So I agree that with Aditya, best is to admit and treat it as if it is going to develop into a pancreatitis, rather than with ongoing pain, rather than just say that it is a post-ERCP hyperamylasemia.
Absolutely.
Yeah, I agree with Pankaj. But because this patient has got a pain, it cannot be ignored, and he has a severe pain, so he's likely to develop post ERCP pain. So he has to be admitted and carefully observed.
Absolutely, yeah. So I think this was mainly to cover that within first 24 hours we don't label them, although it could still be pancreatitis, and therefore you have to manage them as if you are managing a patient with pancreatitis. Going to the third case, a 7-year-old boy has a colorectal cyst and has recurrent episodes of pain. Now has come with pain, fever, and jaundice, which is not responding to antibiotics for last 24 hours. Dr. Vikas, can you take this question? How will you plan an ERC for this patient? First of all, will you plan an ERC? When will you do an ERC for patient with colorectal cyst, and how do you go about it?
Yes, sir. Interesting one. Actually, see, a patient, if he is a diagnosed case of colorectal cyst, I mean, right now it appears that he had recurrent episodes of pain, but right now he appears to be in cholangitis. So pain, fever, jaundice, all the criteria have been set. So I would not wait for any other imaging, I would like to say. I would straight away plan an ERCP in this patient. A young boy, I would just like to have a physical look at him, how tall, what is the stature, so that to decide upon the scope. Mostly, and in a 7 years, we should be comfortably able to put in an adult ERCP scope, but sometimes they might be stunted, very short. So you might need to use a different scope as well. The other thing, since he's into cholangitis, I would like to obviously, first, this patient would not be treating him on OPD basis. I would be treating him on with admission. I would like to give a pre-op antibiotic in this case, so that it takes care of the infection. I would also try to look at his lab parameters, especially the coagulation profile, because with cholangitis, they might have some amount of deranged INRs, which we would like to correct before the procedure. Third thing is, while doing an procedure in these patients, we would be very gentle while manipulating in the duodenum, because small kid, the duodenal wall could be very fragile. So locking, unlocking, reducing the scope should be very careful in these patients. Once I try to cannulate, we should keep in mind that colorectal cyst is many times associated with anomalous pancreaticobiliary. If these patients, which I have personally experienced, if these patients have a long common channel, mostly the wire tends to go inside the PD, and I had this problem repeatedly because of the long channel, it tends to slide in the PD. So if it is recurrently going into PD, as Sridhar has previously talked about, either putting a PD stent or using a double wire technique to cannulate the CBD as early as possible should be the way to go about it. The last thing is, once we cannulate these patients, we should not just hurry to take a cholangio because it appears to be in cholangitis. We should try to take an air cholangio so that it gives us a fair idea of what problem is there. Is there any stone? If there's a small stone, patient is relatively okay, I would do a sphincterotomy. I would take a balloon sweep so as to clear the stones so that his jaundice gets relief. But if it's a big stone getting impacted there, I would defer a sphincteroplasty in this patient. I would just put in a stent so that the cholangitis settles down, and I would try to achieve the biliary clearance in probably subsequent ERCP, and I would like to settle down these patients. And probably while withdrawing the scope, I would take care that the entire air is sucked out, because a small child and desaturation might happen. So that should be also taken care of while doing this procedure. And obviously, post-ERCP pancreatitis has to be kept in mind as choledochal cyst with these things. So all those measures such as rectal suppository and IV fluid should be taken care of.
Thank you, Vikas. Just two quick questions and comments. One is, will you aspirate bile in this patient as much as possible before you inject contrast?
Yeah, definitely. I mean, if suppose an MRCP is done and really I'm sure of the diagnosis, I would probably just aspirate just to document cholangitis and to reduce the rate of complications. And otherwise, I would not try to use much of contrast, because if we inject too much of contrast or it goes into the biliary radicals and already in a setting of cholangitis, I would like to defer into it. But yes, aspiration of contrast both for diagnostic purpose as well as to reduce the rate of complication is a very good option. Yes.
Okay. Yeah, because usually these choledochal cysts do not drain well, even if you put in the stents quickly. So sometimes just decreasing the amount of infected bile may help. Again, no evidence to support this, but I think this is a common practice which most of us would do. The second question about it, will your approach change depending on the type of choledochal cyst? Supposing it's a choledococele, or if it's let's say a intra plus extrahepatic choledochal cyst. So how does your approach change in these patients?
If barring type 5, which should not present this way, all other can be managed by ERCP, especially if they present with cholangitis, because they all have extrahepatic component, so which needs to be taken care of. Yeah, one thing would change how dilated the CBD is. That would help me to decide whether I need to put in a straight stent or whether I would decide putting on a pigtail stent, because straight stent might migrate inwards, outwards, both ways. So I would particularly use a pigtail stent in cases of choledochal cyst, because that CBD is too much dilated and that stent might not hold. So putting a pigtail catheter, or very rarely if there is, I would think of putting an NCD, nasocystic drain, nasobiliary drain, just if the cholangitis is severe and I think that there is too much sludge or too much of obstruction is there. So just to keep that CBD flushing, I might think of putting an NBD. But these two extra precautions I would take care of while doing an ERCP in these patients.
Thank you. Any other comments from anybody?
I have a couple of comments, come question. In a very hugely dilated CBD, sometimes we face this practical problem that when you're doing a balloon sweep, the balloon slides besides the stone and comes out and does not bring the stone out if we are doing it. Obviously, in a cholangitis, we would not waste too much time, but if there's no cholangitis or doing a repeat procedure, when we have to do the stone extraction in a choledochal cyst, especially, a large, huge dilated CBD and the balloon is not completely filling up the lumen. In that case, because would you prefer a basket over a balloon?
Definitely. I mean, yes. I mean, if the balloon 2 centimeter and above balloon, we generally do not get for balloon sweep. So if even the largest balloon is not serving the purpose, because basket could be used to target the stone, and if it comes in the grasp of or it comes in your troll, then it is better option. Yes, that's a very valid point, because in usually dilated CBD, we might sometimes face this problem. So basket could be used in those situations. Again, doing a wide sphincterotomy and as sir said, after aspirating the contrast or aspirating the sludge and the bile collected, these sometimes tend to get decompressed as well. And lastly, if nothing is serving, put a stent, come out, it might decompress the system, so that next time when you are trying to enter it, probably you get a more decompressed system, and that time you can remove the stone. Lastly, a spyglass could be used anywhere, but these options could be kept in mind. Yes, for sure.
Thank you, Vikas, for these comments, and thank you, Meghraj, for bringing this up. But I have a couple of comments on this. One is if the patient has come in cholangitis, I think the key here is to just get rid of cholangitis, and we may not attempt to clear the stone. The second is it also depends on the size of the stone and what are we going to do eventually after the cholangitis settles. If we are planning a surgery and if you have a large stone, I would rather leave the stone back, put in a stent, settle the cholangitis, and go for a surgery where the stone can be removed along with the choledochal cyst. Yes, but if I'm not going for a surgery, a very elderly person who is in cholangitis, then I think we will try all these measures as we have discussed very appropriately. But in usual situations, because it is difficult to remove these stones, because the choledochal cyst is dilated, the stones become huge, and there is an undilated segment of CBD below it. And then it becomes very difficult to extract the stone from below. Thank you, Vikas and Meghraj, for those points. Going on to the next case, this is an 84-year-old gentleman who has got a hilar cholangiocarcinoma type 3A. He's got a bilirubin of 22, SGOT-PT of 123 and 89. He does have low-grade fever, and he is planned for a ERCP. So as expected, sir, the most difficult cases go to the most senior people. So this case has come to Dr. Rathi. To add to the spice, there is also CKD stage 3. And so this ERCP is being planned. Sir, how would you approach this patient for PEP prophylaxis?
Before doing ERCP, I would like to have MRCP of this patient to have an exact roadmap. Because if the right duct is involved with hilar cholangiocarcinoma, the better would be to do PTBD and internalize the stent. And also it depends upon if the disease is going into the right anterior or posterior duct, or whether it is only in the main right hepatic duct, and how much is the hilum and the common hepatic duct is in. So to have a good roadmap is very important in this patient. So I would like to have a MRCP before planning ERCP.
So this patient actually has involvement of the right main just beyond the confluence. The right anterior posterior both are free and communicating.
And hilum
is involved, sir. Hilum is partially involved, but you can see that there's some communication between the right and the left.
ERCP can be attempted, and if I could pass the guide wire into the right anterior or posterior along with left, and one can pass 2 stents, but otherwise the percutaneous way one can pass the guide wire, and over the guide wire then you can either put the plastic stent or metal stent.
Sir, what will you do for prophylaxis of pancreatitis in this patient? Would you give him any prophylaxis? Will you think of giving indomethacin because the patient has CKD? Would you give him fluids the way you would give for any other patient because of the age and the CKD? Means that is another big question in this case. So what will be your strategy for that?
So this patient has a CKD, which is a relative risk factor for the development of post-ERCP pancreatitis. Also, age is 84 years. So, and giving aggressive hydration is absolutely no because of the risk of development of ARDS and pulmonary edema. So if at all fluid is to be given, you have to be very cautious. And again, indomethacin can be given in this patient.
Okay. Thank you, sir. Thank you for bringing those points. So this is a patient who is will be at high risk for fluid as prophylaxis because of his age and CKD. So elderly people with comorbidities, especially cardiac, or patients with chronic kidney disease were all excluded from most of these studies for post-ERCP pancreatitis. So there is not much data available for efficacy of fluids or indomethacin or any other therapy for this group of patients. But what experience tells you and what Dr. Rathi just said is, you may think of giving Indomethacin into this patient. Again, probably will be without much evidence and with probably some unknown risk. But I think that is what best we can do for prophylaxis. And I think the best prophylaxis, which Dr. Rathi said, is if you can go ahead and do a PTBD in case there is the confluence of right anterior posterior is involved, or it's going in, it's a type 4, or if the hilum is completely occluded, then you would go for PTBD. I think that would be a very, very intelligent choice in somebody with comorbidities and at that age.
And you can put a pancreatic stent in case you are inadvertently cannulating the pancreatic duct. You can easily place a pancreatic stent. This would be the only thing that you can probably do in this situation. And suppose it is a very difficult situation, and even if you're planning a metal stent placement, you could put a plastic stent inside the PD to prevent that.
Sir, I mean, just a quick question. I don't have to back this up, but in extreme elderly people, somehow we tend to see actually much lower rates of pancreatitis. Sure. Do you concur?
Yeah, the pancreatic duct is usually dilated and the risk of pancreatitis is much less. It's not a very high risk situation for that. But sometimes if the cannulation is difficult because the lower CBD is little collapsed and you are going into the PD and you are, committed because the patient may have mild cholangitis to drain the bile duct, then of course that is the only option which you should do that, which can be done.
Yeah, I agree with Pankaj. If inadvertently you have cannulated the PD and injected the contrast or guide wire, then PD stent. But here I would like to do early pre-cut sphincterotomy and fistulotomy higher up in the papilla so as to get access into PD.
Yeah.
Great. Thank you. Thank you very much. Going to the next case, 54-year-old lady during cholecystectomy was found to be cirrhotic, probably NASH related. That is what was labeled. She keeps on getting right upper quadrant pain. And the transaminases, they intermittently increase up to 2 times upper limit of normal every time she has that pain. Now, an ultrasound and MRCP shows CBD of 11 millimeters, but there is no stone or stricture seen. There is no cystic duct remnant or any stone within the cystic duct remnant. So this is what is happening. Other causes of the right upper quadrant pain have been ruled out and investigated extensively in the last 2 years after the cholecystectomy. So at this stage, Dr. Dhawan, this patient is referred to you. What would you do? What do you think we are dealing with and how do we approach this?
No, so this is a post-cholecystectomy situation complicated by underlying chronic liver disease with elevated transaminases, and importantly, the patient has got ongoing pain, which is a prominent thing which is happening. So obviously, even if the MRCP is normal, I would definitely do a good endoscopic ultrasound, both to see for any sludge or small stones in the CBD, which can sometimes be missed on the MRCP. Particularly if they are less than 2 or 3 mm, they can sometimes be missed. And although the MRCP is saying that the cystic duct remnant is normal, but we would try to even image that on endoscopic ultrasound and, see whether there's anything in the cystic duct stump or the Hartmann spout. Sometimes there could be something there. So that can be well visualized. Also on endoscopic ultrasound, you can see whether there are any collaterals because the patient has got chronic liver disease. So that's another thing, particularly if the patient is going for ERCP now, just in case you're planning that, then you would like to look for any collaterals around the pericholedocal, collaterals. So that would be the evaluation, which is very important in this patient. Now, the only issue is, suppose the endoscopic ultrasound is normal, then what?
Yeah, which is exactly the case actually here.
That's the more practical thing. I think that if the EUS is normal in this situation post cholecystectomy, the issue is that, whether the transaminases are related to the NASH or is there any other drug related issue or any other issue which is there, which is, related to the causing the elevation. But if there is pain, then which is of this kind, which is more like a biliary plane, with a dilated CBD, then the issue will be whether you will want to do a sphincterotomy at the end of the day. And so if you are going to plan that, I think you have to discuss it with the patient that this is what it is. There will be some chance that there will be a complication and there will be some chance that there will be no relief. So it's a very gray zone in this particular patient. But if you have ruled out everything else, even if the EUS is normal, there could yet be a role for doing a biliary sphincterotomy a selective biliary sphincterotomy, and that may relieve this problem.
So this is actually a case which I saw last week, this is exactly what was the thought process. I completely agree with you.
Yeah.
So here is a patient who looks like a biliary colic post cholecystectomy, but there is enough reason for the transaminases to be intermittently high because of the NASH cirrhosis itself. The pain is biliary type, so and the transaminase intermittently increasing also fulfills the criteria for sphincter of Oddi dysfunction. The CBD is dilated 11 mm. There is no stone or stricture which is seen. So, coming back to the question, it's really a gray zone, and any decision here is difficult because these are the patients who are also at high risk of post-ERCP pancreatitis. And if they get pancreatitis and they already have cirrhosis, they can have real bad decompensation of the liver. And here is a patient who is otherwise having a fully compensated cirrhosis because of a procedure for relief of pain, which is intermittent, infrequent. We may actually decompensate the patient and push her towards more invasive things or even risk of mortality with pancreatitis. So this is a very, very difficult situation. And as Dr. Dhawan said, probably you will sit across the table with the patient and the family members and discuss the pros and cons of everything. And I think if the pain episodes are infrequent and happening, let's say once in 6 months and affecting for only a few hours, you will probably leave her at that. But if they're more frequent and affecting the quality of life, then probably it will be worthwhile taking the risk. So here the patient will have to probably earn the ERCP.
Yeah.
That's what was my thought process. Any other thought process in this patient?
Akash, one quick comment. See, this kind of picture sometimes could be seen in people who consume opioids. Opium. Very good paper by Dr. S.S. Sharma. Rajasthan farmers, they cultivate opium and they consume also, and they see a lot of this SOD dysfunction. So I'll take this history of opium consumption. And second, sometimes periampullary diverticulum with extrinsic compression may cause dilated CBD.
Yeah, that is very true, which can be diagnosed with the side wing endoscopy, endoscopic ultrasound.
Yeah. Thank you, Dr. Rathi. I think both are extremely important comments. One is we should always take the history of opium in these patients because that can be precipitating, and there could be a periampullary diverticulum, which can sometimes cause a rise in the increase in the size of the duct. Dr. Meghraj, you wanted to say something?
Yeah, Dr. Dhawan, as you these patients ERCP, and if the MRCP is not showing any stone or stricture, EUS is also reasonably clear, but because of the persistent pain and intermittent transaminitis, you decide to go ahead with the ERCP. In this case, would you use contrast at all?
So I'm not you did mention about the did you mention about the echocholangiogram? So
yeah, so he's asking whether you'll inject contrast or no, or you'll just do a sphincterotomy and come out.
Showing clear CBD, EUS is showing a clear CBD, but because of the pain and transaminitis, you decide to go ahead with the procedure, explaining the risk to the patients.
So just aspirate the bile and do a sphincterotomy.
No. So you have to do a cholangiogram to document what you're doing. I don't think you can go ahead and just do a biliary sphincterotomy and not do a cholangiogram if you are committed to doing a ERCP. You have to document what you are going to do now. Even from the medical legal point of view, you should do a cholangiogram and just document what you're doing. That is number one. Number two is that I am not a very big fan of a cholangiogram at all. I think your commitment is to drain if you are injecting the contrast, and that should be the commitment. And you have to have a cholangiogram, a good contrast cholangiogram. There is no problem about that.
Would you put a stent, sir?
No, so that's the issue. So I think you do a biliary sphincterotomy. If the cholangiogram is reasonably fine and you're happy with the sphincterotomy, then you need not do a stenting at all because this is a post-cholecystectomy situation anyways.
And would you consciously do a PD stenting in this patient?
No, absolutely not. Absolutely not. You would try to do a selective cannulation of the CBD. In all probability, it will be a success in this patient because it's a dilated duct post-cholecystectomy situation. So you will, in all probability succeed, and therefore there's no need for a PD stent at all.
I think thank you for those comments. Moving on to the second last case, 50-year-old gentleman who has a portal biliopathy He has come for a stent exchange. ERCP done, which is a smooth, uneventful procedure. There was basically stricture in the extrahepatic duct, mainly in the main CBD and the hilum. Both the sides stent was put. Patient develops epigastric pain on the second day, radiating to the back, and amylase is 7,100. So what has gone wrong here? And what will be your strategy for PEP prophylaxis in such cases, Dr. Megraj? It's not so common that after a redo we see pancreatitis, but we have been surprised. So what is the mechanism in these patients?
Well, to answer the first part of the question, what went wrong? There are n number of things that could have gone wrong, or that could have been absolutely nothing gone wrong, but still pancreatitis can happen. We are all aware and we have seen that even in the smoothest of procedures, patients come with pancreatitis, and sometimes we struggle for 45 minutes, an hour, and to our surprise, there is no pancreatitis and patient just walks home after 4 hours in our recovery room. So what could have gone wrong? Well, patient has come for a stent exchange. So probably using the wrong accessory for removing the stent. So spending a lot of time near the ampulla, fiddling with the stents. For example, if the stent is going too long into the D2, D3, there's no point trying to open a snare and grab it and try to fiddle with the ampulla and touch the stent multiple times. In such cases, I would normally go with straight away with a rat tooth, take a good rat tooth, the good grasp and a wide jaw, and hold the stent and bring it out. Second is there is a possibility that this is portal biliopathy. So there are stones that are formed, and because of the worry of inadvertent intra CBD varices, we probably are not very aggressive with the CBD clearance. So a residual stone remaining can also be a risk factor for a post ERCP pancreatitis, even if you have put a stent. You have said smooth, uneventful, so I'm assuming there is no pancreatic duct cannulation. But if that has happened, then again it is a standard risk factor for post ERCP pancreatitis, even though it is a stent exchange. Though a pre-sphincterostomized papilla is supposed to be a protective factor for PEP, but then if you are using a too large a balloon, trying to extract the stone and causing too much pressure at the ampulla, sometimes it can cause a post-ERCP pancreatitis, even in a redo case. So we have to take care of such things, that we don't unnecessarily use too much large balloon based on the size of the stone and the CBD. We have to select our balloon size carefully. And the strategy for PEP prophylaxis now, I think all of us are following that. We do follow the case of rectal indomethacin or rectal NSAIDs in all our patients, even if it's a redo or a stent exchange. And then IV fluids based on the patient's age and comorbidities.
Thank you, Megraj. Just to summarize what Dr. Megraj said, this is a patient where things could have gone wrong with either the instrumentation itself, with the scope directly traumatizing the scope, or the accessories traumatizing the papilla because of the fiddling kept done in the duodenum. It could be also because of a small stone which is left behind and which is impacted at the lower end because of the manipulation. Also because of small space, we do usually do a limited sphincterotomy in patients with biliopathy, and therefore the space may be inadequate, and too many stents may have been placed in a very small with a small sphincterotomy, which may be causing a pressure on the PD opening. So these are the different mechanisms. Dr. Dhawan wanted to add something.
Akash, I wanted to mention one thing, that when you're doing the ERCP in the left lateral position, what happens is sometimes inadvertently, of course, Megraj mentioned it, inadvertently you're putting the accessory, particularly if it's a balloon or a basket, into the PD, especially where there's no contrast. So that, sometimes can be a real disaster situation. A simple stent exchange, and you just got it into the wrong axis. And sometimes the PD and the CBD opening is very close, even if it is a post-sphincterotomized papilla.
Sir, I would like to add one thing. Hello?
Yeah, Vikas, please go ahead.
I would just like to add, we had a case similar, and I remember that next day the patient, apart from developing pain, also had developed jaundice. We went inside, so she had a big hematoma there. So
Yeah.
probably post procedure or during procedure, she must have bled. The hematoma must have happened. It must have blocked the CVD. Probably it has blocked the PD opening as well for some time transiently. So that might be one reason. Even in ongoing bleeding or a big hematoma forming there could be a one reason, because varices intraductal could be present in such cases. So
Yeah,
that
I totally agree with Vikas. I think that is the very common cause, in fact, in such kind of patients. Portal biliopathy, when you do stent exchange, and if patient develops pancreatitis, mostly it is because of the clot at the papilla, and there is a bleeding oozing from the papilla when you do a stent exchange, and that big clot can cause an edema there at the orifice of pancreatic duct, may cause pancreatitis. What do you feel, Pankaj?
Yeah. For portal biliopathy, particularly, I think it is a problem.
Yes.
But
Yes,
you
yeah.
know, delayed problems are little uncommon, but yeah, that's an important issue.
So
Just
thank you very much, Vikas, for bringing that point out. Actually, that is what had happened in this patient. So this patient, we actually went in the next day, and there was a large clot which was sitting right at the opening of the ampulla, and we removed that clot, and obviously the thing improved. But of course, we were fortunate that we picked it up within the 12 hours of the procedure actually getting over. So means the next day morning, we picked it up and we went ahead. But this is extremely important for us to remember that when we are doing stent exchanges for patients with biliopathy, it's a very common tendency that if the patient has started bleeding, you put in a stent and you quickly come out. Actually, you have to stay in there and ensure hemostasis and that there is no active bleeding when you are actually coming out. So I think that is one of the key things which we should remember when we are doing ERCPs for patients with biliopathy. Coming to the last case, a 66-year-old lady, suspected distal cholangiocarcinoma, deeply jaundiced, and operable. And difficult cannulation, a pre-cut is done. The contrast was injected from the ampulla after the pre-cut because the deep cannulation was not being achieved. And it showed a long common channel with a cutoff beyond the PD takeoff, and the contrast has gone into the PD for this patient. So, sir, what should be done? Dr. Ratik, can you take this patient up?
Yeah, first of all, I would not like to inject contrast without deep cannulation. So if your cannula is 1 or 2 Mars or just engage the papilla, this is what you can land in problem. So guide wire, if guide wire is deep into the CBD, then only I'll inject the contrast by pushing the cannula or the sphincterotome deep into the CBD or the guide wire. But inadvertently, if some resident has injected contrast and it has gone into the PD, then I would like to put a PD stent 5 centimeter 5 range and do a pre-cut sphincterotomy, fistulotomy higher up in the papilla and get a selective access into the bile duct.
So any tricks for getting into the CBD in this patient? Because the pre-cut has already been done. So you can visualize the common channel. So how do you negotiate and preferentially put the wire into the CBD when there is a stricture right at the confluence of the anomalous junction?
So one is a septotomy. Second is you can pass the guide wire into the PD and then try to cannulate CBD higher up at 12, 11 o'clock position with sphincterotome by bowing it. Third is a pre-cut at 12 o'clock in over the papilla and fistulotomy and getting access into the lower CBD.
Any specific wire you will prefer for such cases?
Preferably Terumo wire and glide wire is I'll prefer in this patient.
Dr. Dhawan, you would want to add anything?
Yeah, I think the key will be to you know, let the assistant do the job actually, because his role is actually more than yours, and you have to use a hydrophilic wire. So and if it's not successful, you can change the wire. That's one thing that you can do, which adds to the cost, of course. But you can use 1 or 2 guide wires, and usually it will succeed after the pre-cut.
Great. So, Dr. Dhawan, would you like to just briefly comment, because we cannot take all the cases or the situations, but pancreatitis after a pancreatic ERP, How common is that, and in which situations do we usually see them?
So there are the issue is that if you are doing a endotherapy for chronic pancreatitis, in that situation the risk is quite low. That's because, of course, it's a kind of a dead pancreas, and the risk of post-ERCP pancreatitis is very low. Earlier, we would think that if you're doing endotherapy for a situation like pancreas divisum, then the risk of post-ERCP pancreatitis is high. But now we know that, that may not be true. So that is not necessarily a risk factor for, post-ERCP pancreatitis. That is pancreas divisum. The issue is that if you are doing a ERCP for an ongoing acute biliary pancreatitis, then that's the crux situation now. So in a patient where you're doing a semi-urgent or urgent ERCP and the patient has already got biliary pancreatitis, and that's the situation where you have to be very careful of not, fiddling around, because there are very little options in that. You don't have any of these prophylactic options. You can't put a pancreatic stent. So the key thing will be the technique. That's what you have to concentrate on, and not inject contrast. Don't go anywhere in the, in the pancreas at all. And as Sridhar mentioned, that maybe there will be a big role of early pre-cut in that situation if you're finding some difficulty. So that's how, you have to tackle these groups of patients.
So which pancreatic ERCPs would you think of giving prophylaxis with either indomethacin or fluids or any other method?
So in chronic pancreatitis, we don't give any kind of prophylaxis. In chronic pancreatitis, and you're doing endotherapy of whatever kind, we are not doing any prophylaxis at all. For pancreas, that's what I say, for, like pancreas divisum, for example, that, we tend to give at least indomethacin. You're obviously going to put a pancreatic stent and you're going to do a pancreatic sphincterotomy. So we tend to give indomethacin or diclofenac in that situation. Also, we need to discuss amongst ourselves and for the audience also, that are we going to give, like ESG mentions that indomethacin should be given before all ERCPs. So are we saying that we have to give it before all ERCPs as a general, or we have to stratify and strategize the patients by pre-procedure evaluation and then decide, is something that we need to discuss as well.
So let's start with you only, sir. So I completely agree with you about chronic pancreatitis. I don't think any one of us is giving any prophylaxis for patients who have a chronic pancreatitis. Maybe for divisum, sometimes we do give. But I don't think for any other situation we are giving. Anybody is having any other practice with regards to pancreatic ERCPs? Dr. Rathi, Vikas, Dr. Meghraj, Aditya. Aditya has been very quiet.
What said is fair. We don't, for CP, when you're doing endotherapy, we generally don't go ahead with the prophylaxis. So that seems fair. Regarding Sir's thing of giving indomethacin for all other ERCPs, I think unless there is a significant contraindication for rectal NSAIDs, my personal opinion is we should go for rectal indomethacin in all patients, because there is data now to show that it does reduce the risk of PEP. And even if the patient has no so-called risk factors for developing PEP, we all know that any patient can develop a post-ERCP pancreatitis. So we are trying to follow that now, that unless there's an obvious risk factor, rectal NSAIDs are being practiced at our center for all patients who come for ERCP. I don't know. What about you?
Yeah, so I usually give rectal indomethacin now. Previously, we were giving diclofenac. Now that indomethacin has become available, we are using. The contraindications, just to, in a lighter mode, I think is somebody who has got ulcerative colitis and primary sclerosing cholangitis, where you may actually have two contraindications, one for doing the ERCP and the other one to give the rectal indomethacin. So, anybody, Dr. Rathi, what is your take?
Yeah, I agree.
Vikas, yes.
The last thing I would like to add, we've done n number of times ERCPs in, as Sir mentioned, since Sir has mentioned pancreatic divisum. I think pancreatic divisum, minor papilla therapy, we have done many times for acute recurrent pancreatitis mostly. But in my experience, I have not encountered pancreatitis happening because of a failed minor papilla cannulation. So I really don't know whether it will really help to relieve that pancreatitis which is happening. I just wanted to ask other people whether they have seen pancreatitis happening because of failed minor papilla therapy. I don't know. I've never experienced that.
So the issue is that recurrent pancreatitis is a risk factors for post-ERCP pancreatitis anyways.
Yeah.
That's a major risk factor. Once you have recurrent pancreatitis, that becomes an independent risk factor for PEP.
Yeah, but after minor papilla,
whether it is gallstone induced or it is divisum induced, so you're getting into all that right now. So yeah, so that's how it is. But if you have recurrent pancreatitis of whatever cause, it's a risk factor for PEP.
So about Dhawan sir talking about whether we should be selective in which patients we should be giving versus a generalized policy to give to all patients. Now there is data to say that pre-procedure is better than post-procedure. Now there are procedural factors which will actually impact the risk. So so in that case, I think considering the safety profile, the cost, it's better to give to all rather than actually wait post-procedure.
Yeah, I agree with you. It's better to give to all. But what they recommend is ideal time to give is just before cannulation.
That's true.
Yeah, that's true. That's true.
But that is very difficult.
That sometimes might become.
Because you don't know when the cannulation will happen sometimes in a teaching institute.
And plus the position of the patient that time.
Correct.
Supine.
Yeah, but I agree. So most of us would give actually just before starting the ERCP, which technically becomes just before the procedure, the cannulation. So I think that was the last point. At this stage, I would like to really thank GRS and all my panelists for participating in such a wonderful manner. And thank you very much. And I will hand over to, and thank you, Hetero, for coordinating for today's meeting. I'll hand over to Hetero now.
Thank you, Akash. Thank you, Pankaj. Thank you, Meghraj. Thank you all.
Thank you, everybody.
Thank you. Thank you very much.
Thanks a lot.
Thank you. It was nice interacting. Thank you very much.
Thanks to all my audience for very much to my moderator, speaker, and panelists for the program. I would like a great thanks from the team Hetero, and thank you very much for giving an opportunity to be the part of this scientific program. Thank you, everyone. Thanks to all the audiences. Thank you.